Good evening. I'm Shira Kirsh. I'm a speech pathologist, and I want to talk tonight about voice therapy for singers. I thought it would be really interesting, and I thank Mike so much for inviting me to come and have this opportunity to talk to you. So, a little bit about me. I'm a speech pathologist. I have a master's degree and a certificate of clinical competence from the American Speech, Language, and Hearing Association. And I'm a certified orofacial myofunctional therapist, certified by the International Association of Orofacial Myology. I'm also a certified breastfeeding specialist, although that's not really very relevant tonight. But we encompass all kinds of different functions, including feeding, swallowing, and communication. So there's a lot of swallowing, and we treat the lifespan, those of us who want to. And so I've always worked with infants on up through all ages. I started off in a hospital. I worked 1 year in a rehab hospital and 14 years in acute care hospital. So I did a lot of medical speech pathology, and there was a lot of voice disorders that there were many medical issues in hospitalized patients, but there were also outpatients with different kinds of voice disorders. And so I've always worked with voice disorders, and I've always worked with all ages, and including working with NICU babies in the hospital who had feeding problems. And I still work with babies and for different kinds of feeding issues now. So we work with swallowing and communication communication can include speech, voice, fluency, language, and that may also include nonverbal language. So I want to talk to you about what a myofunctional disorder is, because you're probably wondering what that is. So it is a whole set of disorders that occur when there are muscles of the mouth and the face that develop improperly as a result of compensations that happen. And this might happen due to open mouth breathing, oral restrictions such as tongue tie, and I'll talk a lot more about that in a little while. And prolonged oral habits is another big one, like thumb sucking can really cause these other problems to build up. And over time, people can have all kinds of different issues with their facial and dental alignment and growth of their jaws, and that affects their breathing. It impacts function, and function is going to be speech and swallowing, and chewing and swallowing, speech, breathing, and things like voice and even stuttering or fluency can be an issue that we find when we have these tongue ties specifically. So a lot of the things that we work on help correct those problems by developing proper nasal breathing and proper resting posture of the tongue and the lips, and appropriate chewing and the oral phase of the swallowing. And that is, when I worked in the hospital, I worked a lot with all the phases of swallowing, which include coming down into the throat, above the esophagus, anything above the esophagus. So in this setting, it's more about the oral problems, oral phase of swallowing. And so speech precision and clarity is a large part of what we do with patients with orofacial myofunctional disorders. And we can also improve, besides voice and fluency, things like obstructive sleep apnea, because there's muscles involved, and all these other problems can impact sleeping at night, breathing and sleeping. So who can benefit from myofunctional therapy? Adults and children 4 years and up are most of the patients that can be seen, because they can actively participate in the therapy. And so, there's always going to be special needs cases or kids who are not quite mature enough. And then we have another approach for those who are any age with those issues or younger than 4. We have a different approach, but they still have these issues, but we're going to approach it from an oral motor feeding way of treating them. So some of the problems that these patients might have are tightness or tension in the neck, shoulders, face, jaw, tongue. They might have allergies. They might have a history of reflux. They might have snoring, open mouth breathing at night, daytime open mouth breathing. They may have nasality issues, and they may have difficulty with speech clarity and precision, like a lisp. And so some of the sound substitutions that are very common with myofunctional disorders are problems with the sounds S, Z, SH, CH, J, R, and L. I wonder if any of you are recognizing any of these things yet in any of your students or even in yourselves or family members, because they're really common. So it's just something to think about. You'll hear some of it being a little repetitive, and that's okay because it takes a lot to kind of let it sink in. But it'll be a little bit more interesting very soon, I hope. So what do we do in a voice evaluation? Well, we take a lot of information, and a really big part of that is what are the complaints of the patient. So often their complaints are going to be hoarseness, some or all of these things: hoarseness, vocal fatigue, tongue tension, breathy voice, and pain. I have to say, sometimes people don't come to me because they have a voice problem. Sometimes I identify that there's a voice problem when they come to me for some other reason. So that's why I just wanted to say at the bottom that an ENT consult is really important to have that done when there's any changes for somebody's voice. But if they come to me before they even know they have really an issue, I'm going to say, I need you to go see an ENT and check out what's going on. But during the evaluation, I'm going to take a full history. So that's going to include medical history, social history. I want to know what their routine is like. Are they out in noisy environments? Are they around smoke? And some of the vocal hygiene issues would be things like, do they consume a lot of alcohol or caffeine? Things that could be really drying to the mucosal lining of the vocal cords. But besides that, the ENT reports, if we have them, are really important to see what we're dealing with. I want to know what the diagnosis is so I know how to treat them. It's really informative. And a lot of times I'm going to guess what the diagnosis is, and that information from the ENT visit is going to confirm that, or maybe it'll give me some other information. I'm going to also look at their anatomy, physiology, and find out about their function. I already talked about the vocal hygiene. Function is really important. How is it impacting their communication skills? If they're professional singers or just, singing for enjoyment, if they are professional speakers, how is that going to impact their work or their other routine that they have? Just a little bit about anatomy, because I'm sure you all know a little bit about vocal anatomy. If not, it's just a little overview. So the hyoid bone is at the very top of the thyroid cartilage, and this whole apparatus that protects the vocal cords. And that is the only bone in the body that's free floating. There's no other, it's anchored and connecting to other muscles with ligaments, other structures with ligaments and muscles. So it connects the laryngeal complex to the tongue because there's extrinsic tongue muscles that come down, they attach to the hyoid bone, and there's other muscles that come from the hyoid bone that go down to the larynx. There's cranial nerve involvement. These are the primarily glossopharyngeal nerve, cranial nerve number 9, and that provides a motor innervation to the stylopharyngeus muscle, which is responsible for elevating the pharynx and the larynx, or the larynx within the pharynx, actually. The cranial nerve 10, the vagus nerve, it's a large nerve that has many branches that supply nerves that innervate the larynx, and it includes the superior laryngeal nerve and its external and internal branches, and the recurrent laryngeal nerve. They all have very distinct roles in motor and sensory innervation of the larynx. And the muscles that are most important are the adductor muscles, are the muscles that bring the vocal cords together. So they add together, and that's the lateral cricoarytenoid and the transverse arytenoid muscles. And the abductors, the ones that pull the vocal cords apart, the posterior cricoarytenoid sphincters, the transverse arytenoid, oblique arytenoid, and aryepiglottic. And then there's the tensors and the relaxers of the vocal cords. The cricothyroid is the tensor muscle, and the relaxers are the thyroarytenoid and the vocalis. And so that's really important. I just want to also say that we have different terminology. So we'll call the vocal cords vocal folds. And I know that it's different for what other people refer them to, but it's the same thing. So I wanted to talk about the most common things that I see singers or other professional speakers have when they have voice problems. there's three main things I want to talk about. So muscle tension dysphonia. This is where there's excessive muscle tension in and around the neck and the larynx, and it can cause vocal fatigue, unreliable voice, voice breaks or pitch breaks, breathy voice, difficulty singing, hoarse and rough vocal quality, and increased vocal effort. So you see on the left there the picture of the inflammation that can occur with muscle tension dysphonia. Sometimes I don't think there is something visible like that, but when they come back from the ENT and they don't have this kind of a photo that they can show, I really think that there's still the tension. It just hasn't gotten to the point where there's this much inflammation. So the muscle tension dysphonia can be primary or secondary. The contributing mechanisms to it can be psychosocial, something about the autonomic nerve system reaction. So like when people are in a lot of stress and they have chronic stress, they go into fight or flight a lot. That can cause some of these tension in the muscles. Respiratory problems, postural issues, sit up taller, inflammatory problems, and neuromuscular problems. So there's lots of things to consider when you take the history. You want to find out what things might be contributing to their problem. So voice therapy, it aims to provide exercise and techniques to improve speech production subsystems that work together to create the voice. So that's the respiratory system, the phonatory system, and the resonatory system. The second and very common thing I see are vocal nodules. These are non-cancerous callus-like bumps. They occur on the anterior 2/3 of the junction of on the vocal folds or vocal cords. So the picture you can see on the left, their vocal cords are very flush. There's no space when they come together. And on the right, you see I think you can see it. You can see 2/3, I don't know if this shows up. Right there, yeah. Right there. That's where it usually occurs. And you can see how the air, there's no closure on those two parts. So a lot of air comes through, they become very breathy sounding. So it's due to chronic overuse of adduction of the vocal folds, so phonotrauma. There could be straining, yelling. They might be belting a lot without proper warm-up or some other mechanisms where they're putting too much tension. This can relate to the muscle tension dysphonia as well. So they can have both together. And so it's caused by this ongoing friction between the vocal folds. So that's the phonotrauma. And I would have to say I see it in children, both genders, or both sexes, but in adults, it's more commonly seen in women. Something about the size and the anatomy of the cords there. So tongue tie, and I mentioned it before, quickly. I'm going to talk a little bit more about it now. Tongue tie is a third thing, and it's not something you acquire like the other two problems. So tongue tie, you're born with it. It's from the developing fetus. That's something that didn't get absorbed fully into the embryo, and then someone has extra tissue. And this, I'll talk a little bit more specifically about what that means. But the voice symptoms that might be related include, again, you're going to hear again and again the similar symptoms that might happen across all these things. So people complain about vocal fatigue and poor vocal endurance. They might have strangled notes, choking on sound, loss of the high notes, throat pain, difficulty projecting their voice, inconsistency in the quality of their voice, raspy, breathy, or hoarse voice, and frequent loss of voice. On the bottom, you'll see here lots of different examples of what a tongue tie looks like. It's the tissue that's under the tongue. There's other names for it. Ankyloglossia is the medical term. But I rarely use that. If I write a report, I rarely use that because to me that means it's attached all the way to the tip, which I don't know if I have one that's completely detached here, but you can see the second one over is almost all the way to the tip. It has a heart-shaped tip of the tongue when the person is trying to elevate their tongue, like lift it up or push it out. It will have that heart-shaped tip. And tethered oral tissue, so its acronym is TOTS. So it's altered tongue mobility due to the presence of this restrictive lingual frenulum. Frena are the collective name for all these different attachments. There's actually 7 in our mouths that you can have. And when they're restrictive, it's a frenulum. And the one that is sublingual or under the tongue is the one I'm talking about. I'm not going to talk about the other ones. So it's between the tongue and the floor of the mouth. And it's either more anterior, so it's more attached towards the tip, or more posterior, which is more the back of the, not the back of the whole tongue, but it's more posterior from the front, so it's more mid-blade, because your tongue goes all the way down. You can't see the beginning of it in your mouth when you open your mouth. Or you can have both aspects involved. So it can present very differently. There are some, we have these rating scales that are becoming more universally used, so we can really look at the range of motion and to what degree there's limitations in moving the tongue. And it can affect functions that depend on tongue mobility, and this is the important part. It can look tied, and a lot of people who think they know what a tongue tie looks like, well, think from a picture they can identify, oh, that person's tied or they're tied. But it really is what the functions are going to be impaired, how it's going to affect function. The functions are breathing, speech clarity, speech precision. And I can't talk that well right now because I have Invisalign in and I'm still getting used to it. So it's affecting my clarity. Swallowing, hygiene, and voice. I would also say fluency, and I would put that under speech. So how fluent, somebody might have some stuttering issues, and I think we see a lot of that with tongue ties. And this can all lead to compensatory overuse of other muscles of the face and the neck muscles. So this is where people get pain, they get tightness, they get discomfort, and they just kind of always had it and never really knew that it was anything abnormal until somebody points it out that they're not supposed to have this discomfort. I have this toy here for a reason. In our bodies, we have something called biotensegrity. That means that when things are attached, we have ligaments and muscle and other tissues attached to each other. Everything's attached in some way. And when you have some limitation somewhere, it's going to affect the nearby structures. So you can see if I'm pulling on this elastic, there's movement in this the red and the purple or blue wood rod there. And this is what, when I was talking about the hyoid bone being attached to muscles coming down from the tongue and down, going up from the larynx, that's what I mean. That we want to have that hyoid bone should be flexible and it should have the ability to move, and that can affect tongue placement and laryngeal height, the larynx being able to move up and down. So when we're talking about a tongue tie, it can affect these other structures. And people don't realize that. So, that's something that we can educate people on when they do have these issues. There was this very timely research article that just came out about 6 weeks ago or so. And it is about muscle tension dysphonia in singers and professional speakers with ankyloglossia or tongue tie, and the impact of treatment with lingual frenuloplasty and orofacial myofunctional therapy. Frenuloplasty is one of the terms to have that tightness released. So when you have a tongue tie, they usually use a laser, but some doctors will use just scissors or a scalpel, and it takes less than a minute to release that tension. But they have to really know how to do it. It's simple, but they have to really know how. It's not something that you can just go to any ear, nose, and throat doctor to go to. You want to go to somebody who has a specialty in it. But this is the name of it. You might see a lingual frenectomy, frenuloplasty. There's different terminology. So this was really great because my colleagues and I, my friends that I talk to about this all the time, we see this all the time. When we have somebody coming in with a voice problem, 9 times out of 10 there's a tongue tie, and that is very often treated along with other methods, and we get a lot of great outcome. So this was only a small group, 12 subjects, and they had 10 professional singers and 2 professional speakers, And 91.7% reported an overall improvement of the reported symptoms. And the symptoms that they really looked at, and they categorized a few things together that you can see on the right. They had 67% of these, so 12 subjects had an improved voice quality. 58% of them had improved ease of singing and speaking. 50% had increased stamina. 50% had increased pitch range. And 33% had improved breath support. Okay, so it's really important because some of them had all these issues and had improvement. It's not just one subject had one of these problems, or one of these improvements. So it's really more than half, except for the breath support, had improvement in all these other things. So what are the therapy techniques? I'm just going to kind of give you a little overview. One of the techniques that I use all these techniques, but you might find other therapists don't have all of them, or they have different ones, or whatever their tools are. We all go to different trainings and try to add to our bag of tricks or our toolbox to help people. So these are the ones that I use the most. Myofascial release is manual therapy we use to provide pressure against certain musculature. So we'll go to the infrahyoid muscles and the suprahyoid muscles above the hyoid bone. We can go down to the diaphragm for breathing. Even people are complaining of pain, we can go into all the muscles that are involved. And so that reduces pain and it releases muscle tension. So if a patient comes with muscle tension dysphonia, any of the three things I talked about, the vocal nodules and tongue tie, any of those things, they could benefit from that myofascial release. Some of the breathing techniques that I use, and I know that as singing coaches, you probably have lots of different breathing exercises you use. So I don't know if you've heard of these, but one is Buteyko. It was actually made maybe a little bit more famous or well-known by a couple of books. One was called The Oxygen Advantage, and it is by Patrick McEwen, who wrote a lot of books on Buteyko, but it was really about focusing on those who are in performance, like athletes. I would put singers in that category because you're athletes and your students are athletes, or they're learning to become athletes. So it's a lot of reducing overbreathing when they're exerting themselves. So try to limit the amount of overuse. You want to have a balance of oxygen and carbon dioxide when you're breathing. So some people overbreathe, and when you're singing, you're going to put out too much CO2 when you're exhaling, because that's just how it works. So sometimes they need to balance out that imbalance with some exercises when they're not singing. There's a lot more to it, but the other book was called Breath by James Nestor, and that one was a bestseller on the New York Times bestseller list about, a year and a half, 2 years ago. And so a lot of you may have heard of it, but it talks a lot about Buteyko in the book. Another one I really love is Restorative Breathing, known by Lois Laney, and her approach is all about cranial nerve dysfunction and trying to minimize, I would say both techniques help to minimize the fight or flight response. Some people get into this chronic stress and they overbreathe. So that's one part of it. So we want to get the muscles that work the tongue to do the work, and we don't want other muscles to take over. Say if there's a tongue tie in a person and they are using other muscles to do the functions of breathing, chewing, swallowing, speaking, singing. They may overuse their jaw muscles, the masseters. They may overuse facial muscles, and this puts stress on the TMJ. And then over time, there can be all kinds of issues over, years of that kind of compensatory problems that they're using compensatory strategies they don't realize, and then over time they develop more and more problems. So I love those two breathing techniques, and it really helps to work on breathing while doing other things. So restorative breathing is talking about swallowing and breathing together, because that's important to be able to do that. Resonant voice techniques, there's a lot of techniques to use to take the load off the vocal cords if they're being overused. And I know you guys know a lot about resonance. So that's about putting some effort into other musculature that can help share the load. So that's really also, so they're not overusing the vocal cords. And it may just be for speaking during the day, not necessarily during singing only. So that's resonant voice techniques. And there's a lot of different ones. One is semi-occluded vocal tracts. SO, you've heard of that? Everybody's nodding. So that's one of my go-tos for resonant voice. Vocal function exercises. Have you heard of that one? The exercises are a lot like any kind of workout regimen. You're going to have a warm-up. You're going to want to stretch your muscles. You want to bulk up your muscles with some strengthening, and then you want to work on endurance. So that's what we do with the voice for vocal function exercises. So the warm-up has to do with getting a lot of, I know my daughter had voice lessons when she was young, and there was a lot of the nasal kind of warm-ups going through the resonance of the nasal cavity. And then that's the first part, the warm-up. And then there's stretching of the vocal cords, exercises having to do with voicing, with gliding up and down the scale. Voice gym, speaking of sport, this is one of the most fun techniques, most fun course I've ever been to, and the most fun I ever have with patients, because it's very physical. We have a lot of equipment we take out, and it was designed for West End performers, classical performers in the West End. My instructor was an opera singer on the West End, and he started it because he was having trouble with keeping his voice, having the endurance for singing all day and performing 8 shows a week. And so this helped him gain this endurance during physical activity while going from speaking to voicing. So there's a lot of different things using gym balls and balance boards and therabands and all kinds of different twisting movements, and the body's put in different positions because those performers, I don't know how much you work with people who are performing on stage, not just rock music. I'm sure there's lots of different theater. That's really what it's meant for, people who are not just singing, standing, or sitting, but they're moving. And then we already talked about the frenectomy patients, the ones with the tongue tie. So that's a lot of what we do, getting them ready for a tongue tie release, and then the aftermath, getting them recovered from that, and being able to, it takes a little time for that tissue to get recovered, but they're also trying to lengthen the muscle movements. We want to get them to move their tongue and be left with more mobility. So we want them to move their tongue, lengthen the muscles, and it's all about muscle movement. And then myofunctional therapy might also be additional things to deal with the things that I mentioned at the beginning: nasal breathing, tongue resting posture on the roof of the mouth, lip closure. We work very closely with dentists and orthodontists to get patients who can get through their dental orthodontic treatments and work on the changes that they need to make in the mouth while that's going on, to help them get the lasting results. Because if they have a tongue thrust and their tongue is pushed forward all the time, they're going to move the teeth back later. So that's really, there's a lot more to each one of those, but I just wanted to give you a little overview of what that was like. And that's pretty much the talk. So I want to thank you for your attention, and I hope that some of it was informative and some of it may have been familiar, or a combination of both would be great. So, sure.
Go back to that slide where you showed the improvements of tongue tie.
Yes, so, this one?
Right. So
from the research.
I'm not a singer, but if I knew if I can get 10% better being a guitar player, I would do it. So you're saying if somebody cuts that tongue tie, you can show a 67% improvement?
With my functional therapy too. So get the tongue in better condition. So we have to work on the muscle, because remember, it's all about function. If the function is impaired, we want to bring the person back to function, and that's what therapists do. So
someone comes up to me and goes, Mike, I want to get my tongue tie cut. I want to be a better, singer.
Well, then he would come to me, and I'd do an evaluation, and I might say, I don't think there's a tongue tie. That's a possibility, because a lot of people go to Dr. Google, and they think, I have a tongue tie, that's what the problem is. And they come, and I want the tongue tie fixed. So sometimes I do agree, and sometimes I say, well, I don't think that's the problem. It might be other things.
What are some of the signs
So the restriction is that, say, if I go back to the pictures, it's helpful. So the person on the left is suctioning tongue to roof. So if everybody can do this movement, you can do like a horse galloping noise, right? And so we measure that, and we can find out an idea of if it's restricted, if they can't get, well, I'm looking at it, I'm feeling it, I'm getting in there and feeling it. If it's tight, don't worry, it's like with gloves on and everything.
I could really do that.
Yeah, so some people might be beatboxers too. Sometimes the vault of your palate might be too high and you can't reach. So some people can't get the tongue to reach all the way. So they have like they can't get that at all. So some of you might be going, I can't even do it. And that's okay. Sometimes the palate is so highly vaulted, and that might be from, tongue ties can often go along with a high, narrow palate. So a lot of people who've had palate expanders, and they've had that lowered and widened, they can get the tongue to reach better, but sometimes there's still a limit to how much they can get the tongue to rest on the roof. So I don't know if I went off on a tangent or not, but
no, you answered that question. And then the second question was, because I know a lot of the children that come here, some of the coaches might notice a stutter
Yep.
or a lisp.
Yep.
Is that their place to maybe help them work on that? Is there a singing approach in terms of teaching that they can work on, by not telling the student or the parents that this is that you're really trying to help? Because I know it could be an uncomfortable situation with, a coach.
yeah, sometimes they don't. I often say, well, your child has a lisp, and they're like, oh, I didn't even notice. Nobody ever really gets, no one ever seems offended when I bring it up. Sometimes there's a few things that we have to bring to people's attention that we're a little worried about how they're going to react. So you have to kind of read people. But if they have a lisp, sometimes it's because of a tongue tie. Tongue ties are often affecting, I would say a lisp is caused by three main things. One is a tongue tie because the tongue is carried low and forward. And so they get this resting posture that's more low and forward. And then everything becomes low and forward. So the S's, the Z's, their tongue's pushing forward because the tongue tie is kind of pulling the tongue, not always, but it can pull the tongue low and forward. So it's really hard to not speak with a lisp if that's constantly being like a rope holding something in a certain place and you can't. You need to release that so you can get different movement pattern. But another cause of a lisp would be prolonged oral habits. So if somebody was a thumb sucker or a pacifier user for a really long time, and then their tongue became more forward in their mouth because it's being pushed out of the way, that can cause a lisp later when speech starts to come in. And the other thing is if they have problems with nasal breathing and they can't breathe through their nose because of allergies, they might have blockage in the nose. There could be soft tissue inflammation, adenoids, tonsils in the oral cavity. They are going to move their tongue forward to get it, open up the oral breathing pathway. So the nose is always the plan A to breathe through. And your plan B is going to be your mouth. If you have a cold or allergies, you got to open your mouth to breathe sometimes. And then it depends on the anatomy of the patient and their architecture of their mouth and everything. They're going to probably need to push their tongue forward to keep it opening up. If it's chronic, I see people who deal with it for decades and it's never been addressed. Or, even as a child in school or high school, they've developed all these compensations at this point. So a lisp can be caused by a lot of problems. We can identify what those are and, get them on the right track. So, any other questions about anything?
So I had a student that when she was like 5, I think, and she came in and she had like a very hoarse voice, and her mom was there, and then at the end of her third lesson, her mom was like, "Oh yeah, by the way, she has vocal nodes. I don't know if you
Nodules.
know that."
Yeah.
And I was like, "Oh." My understanding is that you have to be very, very careful if you have nodes, especially that young, because you don't want to damage your voice. And because I don't know what's going on there, so then that made me. She ended up leaving because she was taking off for the summer anyway. but I was like worried, like, how do I make sure that they're not hurting themselves
Yeah.
in the lesson? Like, because I'm supposed to be teaching them to sing, but like, whenever I thought about notes, it's always been like this big red flag, like, like, don't sing, go to the doctor, get that fixed, like, don't even speak. So.
Well, I would say if you feel comfortable to refer them for voice evaluation to find out what's going on, or maybe ask them, oh, do they have a cold? You know, maybe kind of like see if they'll offer some information. But if you have someone with hoarseness, you don't know what the problem is just by listening, unless they do know that it's nodules. I would say, well, you probably want to go get an ENT to check that out, or for a voice evaluation to see what can be done with that. Because, you know, we can help them change their habits. Often, nodules are from overusing the voice, and it can be because they have tongue ties, but I see so much with a lot of shouting in the house, there's noise in the house, they're doing a lot of silly voices sometimes when they play, especially with little kids, sound effects and stuff like that. They might have allergies and they're putting more effort. It's all about overusing the vocal cords. They're hyperducting the vocal cords, so it's phonotrauma. But it can be because of a medical condition, so you don't really know why.
So, like, because like in this case, like the mom, like she was like, oh yeah, like we took her and like they said that she had this. And so like my concern was, like I wouldn't be taking voice lessons if I knew I had nodes. Like I would be getting like voice therapy to like get rid of them,
Yeah.
so that like my vocal cords were healthy before moving on to that. And I felt like a little bit scared, like continuing instruction with her. Like luckily she ended up leaving, so I was like, okay, like I'm not worried about hurting her now.
If it's small enough, they can get taken care of with therapy. If they're bigger, if they are getting bigger and bigger, sometimes they require surgery. Probably not in a 5-year-old, but like in an adult. And it's all about finding out what the behaviors are or what the conditions are that are causing them. And sometimes they don't want to change their behavior. So unfortunately, they can all be, like I had a teacher, she just couldn't change certain things. For teachers, I give them lots of strategies, you know, using a microphone, amplification, other breathing exercises they can do in between classes if they have time, like at lunch, things like that. There's lots of different things to help them, strategies to help them, but they should, you know, be changing some behaviors that are going to be problematic, like if they're talking over 3 rooms away to somebody at home over noise and there's smoke, you know, all kinds of things. And did you have a question?
Yes. What do you do if somebody's experiencing, it feels like there's a lump in their throat, but there's nothing there? Even if you went to ENT and they put the...
They feel like there's a lump in their throat.
Yeah, and if you try to swallow, you sort of like...
Yeah.
There's something stuck in there.
That, and there's nothing that shows up on a stroboscopy. Well, I get some patients like that sometimes. They're a little bit more, they have more sensation than other patients sometimes. Sometimes the uvula, I feel, is a little elongated, you know, that punching bag in the back of the throat, back of the mouth. I feel like sometimes it hangs down a little long and it touches the back of the tongue. And I think some people feel it's uncomfortable or they get a sensation there's a lump in their throat. Sometimes they have actual material sitting in their throat they're not swallowing, like saliva that's not always being managed properly. And it can feel, and it could also be just something in the bony structure that they are feeling. So a modified barium swallow is a swallowing test that I used to do all the time at the hospital. And it showed somebody swallowing and we can see the spine and any changes that were affecting, like they have compensations like forward head posture. And that is something that happens when they can't breathe too. So it changes the spine over time. And that can make them feel like they have a lump in their throat. When they swallow, even swallowing saliva, more head bobbing going on. So, but it could be a number of different things. Yeah, again, a ENT consult, and if that's not enough, then a speech pathologist might be able to help with that. It depends. Anything else?
I'd love to hear more about the vocal gym thing.
Oh, it's so much fun.
I'd love to hear more.
What kind of maybe leave that part? Something we can hear. So that's great. I could just picture you with bands and.
So like what kind of things were involved in that? I'm imagining probably like balancing on like the upside down like Lucy ball thing.
There's a couple of different things. I was using it today with someone. So one of the things I love to do, and this reminds me of the movie The King's Speech, that movie, when he had I think he had marbles in his mouth like they used to do the therapy around that. One of the exercises they have is you take a toothbrush and you're brushing the molars on the biting surface while you're reciting this, really unusual, it's all British because they're from England, this poem or anything, you can read anything, but I always give them this really hard to read poem, and they have to talk while they're brushing the surface of the molars, and that's creating mouth space, and it's helping them move their tongue around to try to avoid the brush. So that's one. One of the earlier ones, they're in in the yoga position, the cobra position, and they have to lift their torso up, and the smiling is going to widen certain muscles. I think the stylopharyngeus muscle, one of them, is going to, if you smile, you're widening the muscles behind the throat, or that kind of wraps around, and that helps open up the airway. And they're also twisting and reciting something. So they're twisting, they're coming back to the middle to make sure they've got this big smile. And then they're all in this cobra position doing this. And they're reciting in this position, and this position, maybe in a door jamb, opening up the chest. So it's all about breathing too. And they're sort of stretching. Stretching these muscles are important for pre-frenectomy and post-frenectomy care too. So some of these are just really useful for a lot of that. It helps to, there's a couple of different these techniques that all work on getting that hyoid bone flexible and giving it make sure that it can move if needed. Sometimes it gets a little stuck and people have trouble getting their voice to, maybe it changes the ability of their range and tongue positioning as well. Because remember, they're both connected to the hyoid bone. So a ball, doing a bridge over one of those big gym balls, and you're hyperextending your neck, and you're reciting a poem while you're walking up and down the room. It's fun. And then on the balance board, you might be just doing some scales, some different things, and you might be trying to stand and not fall off, and you're bending, and as you vocalize, you're bending down, you're standing up tall again. So they have to be really aware of their posture. One of the ones with the TheraBand, we're on a ball, just doing some posture exercise, sitting on it, holding it behind, and doing some of these turns while vocalizing. You can stand and I have people who will stand on the TheraBand on one end, and they're twisting their body, holding it in the other hand, and they're changing position, and they're singing in this position, and then they're going to switch and twist and sing in this position, and all different ways. Because these are people who maybe need to move more because they're musical theater people, or in performances like that. They don't even have to be singers. They could just be people who speak on stage and moving, that kind of thing. There's so much more to it. There's a lot of so it's a lot of tongue space, moving the tongue, stretching these tissue, and also the whole body, moving the torso, and lots of different things in that realm. And then when we get to singing songs, I'm not a singing coach. I can barely sing myself. But I have to say, since doing a lot of work with voice patients, I may not sound that great tonight, but I've had some allergies. But I know I'm singing better because I've been addressing the muscles, and at least the little kids like it. I don't know about the big kids. So anyway, it's really a lot of movement and really fun to do. Yes?
Can tongue tie be a reason why some people can't roll their R's with their tongue?
It could be, yeah. Yeah. Sometimes they can't have certain patterns, and I'm always teaching patterns beyond the tongue tie, release, and recovery. We're also working on tongue patterns. So rolling, how many of you can roll your tongue like this? Can everybody do it? You can't. So a lot of times a tongue tie. Sometimes there's tongue ties and people can still do that. Can anybody make that, like, I call it a like flower tongue, where you try to fold and roll your tongue at the same time and it comes out like a, can anybody do that? I used to think that was because you have a tongue tie, but my son could do it. He was tied, but I've seen a lot of people could do it and they're not tied. So it's like origami. I don't know. It's just, they can just fold things certain ways. You can fold it in half this way and this way at the same time, and that's why, and I can't do it that way. I can do both separately, but I can't do it at the same time. And I've tried to learn how, and I've gotten a little better at it. So it can be taught. Anything else?
Are you familiar with mouth taping?
Yes. Yes, I am. How do you know about that?
I've seen a couple of videos on it, but like I don't really like know too much. I just know a lot of people say that it helps with improvement of
Yes.
the quality of their voice.
What is that?
Well, I use it to help people breathe through their nose at night. Is that what you mean for nighttime? It can be used during the day too.
For anything.
So I know a dentist who's in the myofunctional world. Everybody knows this guy, Bill Heng. He's like in his 70s and he just ran his like 11th Boston Marathon. He's done like 34 marathons. And he did the Boston Marathon last month with his mouth taped the whole way. So he can breathe through his nose in a marathon. And he did it to prove a point that you can breathe through your nose even through exertion. Now we can't sing like that. So it's more about, helping people breathe through their nose at night. And that makes a big difference in how much the quality of their sleep is, how well they're getting oxygen delivered to their body, so they're learning better. The kids are learning more when they can sleep with their mouth closed. Lip closed, I used to think it sounded horrible, but they've come out with a tape now I really like that has a window cut out in the middle, and it's made of K-tape. So it's got a two-way stretch. You overstretch it, you place it on, and everything springs close together. So when you're sleeping, it's going to help close the lips, and they don't have to be afraid if they really need to breathe through their mouth. There's still an opening there. It's just, the other tapes go across your face, and so people would be sometimes afraid to cover the mouth. But people always can just take it off in their sleep if they really need to, or wake up and take it off. But I use that a lot with my patients.
Because I'd seen a video of somebody, she was an opera singer,
Mm-hmm.
and she did mouth taping at night for her, because she said that when you avoid breathing through your mouth at night, like you don't get like all the like extra whatever's in the air.
For hygiene. So you're going to have much better filtration through your nose. So if you have allergens floating in the air and they're big enough particles, your nose will filter them out. Your mouth won't, because there's no filter. There's no hair in your mouth. There's no tiny little passageways. When you open your mouth, it's a much bigger space. So it does help you sleep better. You're not going to get necessarily the effect of allergens if you're allergic to dust mites. You're going to get better sleep, but it is going to help with the voice, because also breathing through the nose warms the air and it humidifies the air and filters the air. So all those things are very beneficial. Anything mouth breathing all the time is going to be, cause cold, dry air to hit the vocal cords and can cause problems. We want them to have moisture. So breathing through the nose can provide that. Good question.
Yes.
Yeah. Yeah.
Probably don't get sick.
You're going to start seeing it everywhere now, because it's going to show up everywhere.
No, I'm gonna go on Amazon and I'm gonna get one of those mouth ties. My wife won't let me take it off. I bet she won't all day with it. But I think I'm gonna try it.
Yeah. That'll help with snoring. That's an issue. Is that all? Anything else? You have another one?
Yes, so, do you have any suggestions on like exercises we can do? Like, I have a couple of students that they really can't project. Like, their voices are super, super quiet, and a little bit airy. And, even working with them in voice lessons for a year, and it hasn't changed. They don't seem to have any speech problems. But even they're when they're speaking, their voices are very, very quiet. And so then when they go to sing, they have like a lot of trouble getting like resonance and volume. And do you have any like recommendations on like exercises that you can do in the lesson?
Well, I would just wonder how they're doing with diaphragm breathing. Are they breathing from the abdomen? And maybe have them put their hands across their abdomen and make sure that they're feeling that move. Because if they have too much clavicular or thoracic breathing, it may not give them enough power, and that's going to affect their stamina and their endurance. That's the first thing I can think of, but there may be other problems, but that's a good start. I always start when somebody has a soft voice and it's really hard for them to get loud enough, just speakers, not singers or anything. That's the first thing I'm going to go to is let's work on your diaphragm breathing, make sure it's moving. There's a lot of people who don't breathe down that deep. I noticed when Kelly Clarkson was on American Idol, I noticed she would always sing holding her abdomen, and I thought that was because she wants to make sure she's breathing from the diaphragm to get her power, I guess. Okay. Anything else? Well, thank you so much for having me. This was so much fun.
Appreciate it.